Well, welcome back, delegates. We're broadcasting live from our Cape Town studios here in South Africa. Good evening, good morning, good afternoon, wherever you are globally. We hope that you are enjoying the aortic conference. We hope that the information that's coming across from our presenters are really enriching the knowledge on cancer control and cancer prevention. And certainly we hope that you're also taking opportunity of the various virtual platform opportunities that are available to you on the aortic website, and using this opportunity for you to network and to dialogue with the various colleagues globally. Certainly none of this would be possible without our sponsors, as these are paramount. So we'd like to also pay tribute to our diamond sponsor, the National Cancer Institute, as well as our silver sponsors, Electa, Novartis, Takeda, and Varian Medical Systems, as well as our bronze sponsors, the American Cancer Society, Beckman Coulter, Bristol Myers Squibb Foundation, CEPID, as well as IGCS. And with that, I want to hand over to my co-host, Zaina Mohammed.
Good evening and welcome. So the next session is on palliative care, one of the most essential parts of cancer management, and particularly important in Africa. So I just want to introduce our facilitators, Christian Ntizimira, Emmanuel Lurinka, Nahla Gaffer, and Anna Mary Nyakabau. Please go ahead and welcome.
Thank you very much for the introduction, and thank you very much for hosting this specialist session on palliative care. We are delighted to focus on two major items this evening. We'll discuss access to essential medicines and technologies, and then later my colleague Christian will come and lead us, facilitate on the issue of capturing and acting on patient voices. We have lined up very able panelists this evening, and they'll be able to help us capture this session very well. We know that essential medicines are very important part of the palliative care journey, as well as the technologies, and we can actually have those technologies maybe into 2 or 3 sections. The essential technologies that are sort of facilitators, and those that are used in the actual delivery of services and in actual therapy. So we want to welcome to the panel Dr. Miriam Mutebi from Kenya. We have John Marston from South Africa. We have Dr. Zipi. We have Anna Nyakau from Zimbabwe. And then we have our colleague from Rwanda. And Dr. Christine will also be joining in to support the first panel in discussing this very important issue of access to essential medicines. So let's start let's start in Southern Africa with John. I know John has a very serious bias towards children and towards humanitarian situations. How do you see us respond to the need of essential medicines in the context of the population that you work in, John?
Thank you, Emmanuel. And yes, I do have a very serious bias towards, first of all, children. And I think we are making some progress with children. We have an increase in guidance and guidelines that are helping us. And we have an increase in access to medicines in some countries, although many countries in Africa, of course, are not doing as well as we are perhaps in a place like South Africa. And what really does help is having a national network really focusing on children's palliative care. And I really would encourage every country to set up a national network. and maybe Emmanuel to refresh the African Children's Palliative Care Network. Of course, in humanitarian crises, we have extra challenges and extra barriers to getting essential medicines, but they are included in the various lists, and we do have an increase in humanitarian health responders, not only taking an interest in palliative care, but also Médecins Sans Frontières has appointed a consultant who is working in South Sudan to increase the access. So while there is still a very long way to go, I think that there is some encouraging improvement.
Thank you very much, John. Let's get near to you in Zimbabwe. Anna, how do you see the issue of access to essential medicines in Zimbabwe, and what can we learn from that as the rest of the continent?
Well, thank you very much. As you are aware, Zimbabwe is involved in the integration of palliative care into the public health system, such that there has been lobbying. So the palliative, there is a team that has been working, various groups lobbying for palliative care medicines to be included in the essential medicines list, and that has happened. And also in terms of access to medicines at the level of the practice, we in Zimbabwe, we have lobbied for legislation so that we can get nurse prescription of palliative care of morphine. And this is, we're almost there in achieving this. So yes, Zimbabwe is on the road of actually increasing access to essential medicines in palliative care. There is also trainings to make sure that people are aware of how to prescribe the essential medicines like morphine, because there is phobia in terms of people prescribing morphine, and also even in terms of general awareness of morphine. People can be scared of this medication, and there are lots of myths and misconceptions. Education is also happening to actually make sure that people can accept this as a palliative care medicine.
Thank you very much, Anna. The nurses, without nurses, there is no palliative care. We all know that. On the African continent, without nurses, you don't have palliative care. And I would like to, on that note, to move to our brother, Hategekimana in Kigali. We know that there is involvement in the pain-free initiative in there. And building on what Anna has said, nurses are very essential in making sure that essential medicines reach the patient and actually they get in the patient's mouth. What can we learn from the experience in Rwanda as regards that?
Okay, thank you so much. What I can say is that both nurses and doctors, they are all involved in this step for providing medication. So I think the first step is among the government. I would say the government, if the policy is there, and then we improve the knowledge on prescribing medication, not only for doctors, but also for nurses, because they are the one who are always near by the patient. So they are the one who are sometimes administering those medication apart from prescription. So they are the one who will prescribe,
have we lost our colleague?
Administer those medication. So the nurse has a big load in this medication, palliative care and other pain, mainly focusing on opioid because of that opiophobia. So what we have done so far, it is training all healthcare providers in different hospitals, mainly involving doctors, anesthetists, nurses, and then we try to train them on how to prescribe medicine, mainly opioid, and this come out with a good improvement in prescription. So we have seen the increase in opioid demand. so which is related to the increase in awareness and also knowledge about prescribing medication, including opioid, among doctors. Thank you.
Thank you very much for that information and for sharing the experiences in Kigali. I would like to jump to Dr. Zippy, because Dr. Zippy, you've seen it from both where we started with John in terms of children and the humanitarian situations. And then we come to Zimbabwe, where we've learned from the issue of involving nurses, and then coming to Rwanda, where we see the policy and then equipping the teams, the nurses and doctors. Dr. Zippy, what would you like to add on to that in terms of your observations in Kenya and in other places where you've been involved in working towards availability and access to to essential medicines and palliative care?
Thank you, Dr. Manuel. Again, I'm just I'm hijacking this meeting. Okay, so in Kenya, maybe I'll give examples of Kenya. Is that we now have morphine in Kenya. It wasn't very easy. It took some time for us to be able to do a lot of advocacy for the government to put oral morphine and other opioids on the essential medicines list for this country. And again, also for the government to agree to having a central production of oral morphine. It's produced at the Kenyatta National Hospital, and from there it's sent to the peripheral through the Kenya Medical Agency supply. I think you can have the medicines, but if you don't change the culture of the people, like it has just been said, then it will just be medicines on the shelf. Because before we started integrating palliative care into the public hospitals, we did some site visits to quite a number of places. We actually came across medicines that had expired on shelves, yet there were patients in those wards screaming in pain. We came across patients who had cervical cancer and were from screaming in pain, children, and morphine and the hydrocodone had expired on the shelves because people did not know how to prescribe, people did not know. People were scared of the side effects or the myths surrounding the use of opioids. So there is a need. Like Joanna said, again, everybody has said, there's a lot of need in terms of educating healthcare workers to be able to understand how to use those medicines and prescribe them, and then to use them safely, of course, and also for patients to understand that these medicines are necessary for their pain. One of the things that has helped Kenya a lot to empower people to be able to prescribe and hospitals to stock the medicines is a program we have with the American Cancer Society called Pain-Free Hospital Initiatives. This is a program where we go into a hospital, we work with a hospital and get clinicians in the hospital who understand how to control pain, to give education to all departments in the hospital. They have maybe about 6 sessions on pain management, pain assessment, pain management in pediatrics, in children, in burns, in elderly people. And so this has helped change the attitude of most of the doctors. They now understand that they can actually use medication, pain medicines, even for burns in the burn unit. So again, education is very important. And of course, having policies and government, and education doesn't just stop with the doctors and nurses, because if you don't educate the pharmacists, then the medicines will not be prescribed. So again, the pharmacist is very important because they're the ones who order and stock these medicines. And if they are not on board, so one of the things we also have done a lot in this country is we have educated the pharmacists, especially where there are oncology centers, to be part of the team. So I think it's accessibility is really, it needs to, you have to have policies, you have to have the medicines available, you have to have the government support, you have to have the healthcare providers on board understanding how to use these medicines, but also you need to educate the patients, because patients go online, they read so many things. Patients, the other day I went to see a patient, she had been put on fentanyl patches. The first day she was drowsy, she was elderly, she has a cancer, she's in one of the hospital, and immediately the family was saying, remove the patch. And I was telling them, this is an elderly person, it's a new medicine, she's opioid naive. For the first few days, we will actually see this drowsiness, it will go away. So again, educating the patients so they can understand that these medicines are safe for them is very important. Thank you.
Thank you very much, Dr. Zippy. Advocacy, awareness, educating both providers and recipients of the medicines, policymakers. That's a whole task for us as health workers and palliative care providers. But thank you very much for bringing us up to speed with that. And I think we can learn from both the Rwanda experience and the Kenya experience to build on what our colleagues in Southern Africa have said. Theonest, do you want to take us through some of the experiences you've had with access to essential medicines?
Thank you. I'm Dr. Theonest, as has been presented. Maybe I'm a clinical oncologist at Rwanda Cancer Center, which is like a national center that treats all cancers with radiation and chemotherapy. So since 2 years that I have been working here, we have got some improvement throughout the government of Rwanda in cancer care. However, some challenges present in availing essential medicine. For example, in Rwanda, more than 90% of the population use what we call community health insurance, whereby the population contribute so that when they get sick, they go to healthcare providers, they treat them with some facilitation, then they can get medicine. So in order to get those medicine, the government has to do what they call essential medicine, including cancer care, so that people can, so that the community health insurance pay it. Till now, the essential medicine for cancer care, they have not been put on the package for essential medicine. So it is really a challenge whereby there is not, universal access to cancer care. However, through the will of the government, now they have been drafted the new version of essential medicine, whereby now cancer care is being taken care, whereby now all essential medicine for cancer diseases will be there. And we hope that at least for all diseases that are more prevalent in Rwanda, all patients will get access to treatment. Moreover, we have support from the NGO, like Partners in Health, which provide free access to medicine for some diseases that they have, chosen according to their priorities, like breast, like cervical cancer. However, patients to get them, they need to go to Butaro Cancer Center of Excellence. So we think that soon also we'll be having this good news to our population. However, till now it is still a challenge. Thank you.
Thank you very much for bringing in the whole issue of partnership between government and some of the NGOs, and also bringing us to speed with the issue of health insurance and making sure that we can get the services and essential medicines and technologies through that angle through insurance. One of the things that I think we need to have this whole thing in full picture is bringing on the technologies. We've talked about the essential medicines that are so critical, but we also need to talk about the technologies. And I would like to invite Dr. Mutebi to come in here, because we know specifically for cancer that technologies are so essential in working together with the essential medicines to get the best out of the care system for cancer patients. So Dr. Mutebi, can you please take us through that? Which technologies and how do we make sure that we get the best out of both the essential medicines that we need together with the essential technologies, especially within the context of cancer and palliative care?
Thanks, Emmanuel. And I think you've touched on a key area, especially around the technologies and sort of marrying the two. And so looking at it less from the lens of technologies, meaning these new shiny toys, but looking at technologies in terms of systems and innovations around that. I think one of the key areas that I think we've been lagging behind in is the cost of care, and Theonest has sort of touched on that a little, the fact that patients in sub-Saharan Africa are paying 3 to 4 times the cost of a drug in any similar LMIC, already showing us that we need to do better in terms of our negotiating power. And that part of the innovations around that is trying to look at how do we create regional or continental bodies that can, push for us. We've had some couple of initiatives, and there's been great work by, I would say, the Clinton Health Access Initiative, things like the African Medical Alliance that signed the treaty today. I mean, I think was it yesterday or 2 days ago, in trying to sort of push and trying to get the AU to really sort of think critically about how do we lower the cost of care for patients. And so those are part of the key areas that we need to look at. But even going beyond sort of improving the regional negotiation, it's how do we improve our in-house capacity to produce? And I think that has been one of the missing components for most of the countries in sub-Saharan Africa. And this kind of came to a head, I would say, especially around the pandemic, because we had a couple of countries and a couple of my patients who are from across East Africa who were saying, listen, we can't get drugs coming in. Can we, perhaps get somebody to come and buy them in maybe Kenya or send them back? And we're like, we shouldn't be in the situation where we're having to negotiate or figure out how we can get these drugs safely to our patients. And so perhaps we had a preliminary survey around, and this was work done by KEMRI, and I think ZP probably was also party to that, in sort of looking at how do we improve our in-house regional capacity to produce medication. And it was very telling discourse, because they talked to manufacturers and they were saying, give us the tools, give us the templates, give us the resources to maybe generate, maybe with stoma bags, if it's medication, how can we sort of engage them? So it's that multi-stakeholder scenarios that we do need to sort of think about as we build towards technologies. Of course, digital health has helped to, in the one sense, democratize access, in that there are more apps and things. And I think Eva talked yesterday about the borders, where you could coordinate transport to drugs and stuff, but also in looking about the digitization of medication, for instance. There's no reason why the drugs are maybe expiring on the shelves, whereas they could be mobilized to areas where they're required. So all these kind of technologies need to merge, but I think the key issues are around looking at our own ability to produce some of these drugs and provide them at a safer, cheaper, more accessible manner to our patients. Thanks.
Thank you very much, Eve, for Miriam, for that very enlightening presentation. I want to push it a bit more, and because in the palliative care fraternity, we tend to think about essential medicines and we forget the technology bit. And more still, for cancer patients, we forget the technology that is used as in delivering as a treatment modality. For example, radiotherapy, we know that the African continent is one of the continents with the worst coverage of radiotherapy. And yet we know that in palliative care, there are aspects where the only solution could be actually use of radiotherapy as a treatment modality, as a technology. What would you like to say about that? And how can we, as palliative care providers, get involved in that and ensure that governments actually invest more into that?
I think it's calling for really a call to arms for that multidisciplinary approach to care. And again, also trying to embrace the fact that, again, with some of we do need to provide, I would say, more access to these services, because sometimes you have a patient who needs maybe palliative radiotherapy, but you find they're far from the centers that can access those. So in terms of trying to, increase the number, but also the access. So in decentralizing some of these radiotherapy services has been part of the drive that our National Cancer Control Program has been doing, but also I would say educating healthcare providers around these aspects of care, because if the person who's looking after the patient is not necessarily aware of these newer techniques or more streamlined precision say radiotherapeutic services that could provide, a measure of comfort, then they're not necessarily going to make the referral. So I think it comes down, one, to just strengthening the base of the multidisciplinary team, having this regular sort of discussion and interaction around what are the different approaches to care, and sort of looking at a 360, what are the different dimensions that we can all bring to the table will go a long way towards improving access to these. But then now as a team, just really pushing our governments and policy makers to ensure that these technologies are more available. And I see Zippy's just listed a interesting resource. Thanks, Zippy.
Thank you very much, Miriam, for that. I want us to go back to Joan. We've been talking about all these things, and they all seem to appear within the context of a stable population where we need to bring the medicines, we need to bring the technologies, we need to bring the services, we need to train the people. And then you have those who are vulnerable, the children, of course, but also those who are in humanitarian situations. You know that in the region, we have quite a big number of displaced populations. We have millions in Eastern Africa. We have more in North Africa. We have in West Africa and in Southern Africa. Joan, what do you think we could do to improve access to these services, the essential medicines and technologies, to those populations for whom the host countries may not even have planned, and they are already struggling with their own populations, and yet they also have conditions for which these services are needed?
Yes, Emmanuel, I think that really is a huge challenge. And I think if we look at it from a global point of view, you have all the UN agencies that are involved in the humanitarian response, from the Office of the Coordination for Humanitarian Affairs, UNICEF for the children. They all have a tremendous focus on developing technology. And I think apart from the education that we've been talking about and integrating it into humanitarian health response, where we have these really well-organized groups, the Red Cross, the Médecins Sans Frontières, those type of groups, is that has to be integrated. But I think also the use of technology, technology which is not only to provide the service, and that technology can link people and health workers in humanitarian situations to outside expertise, so telemedicine, but also the use of drones as being used in certain countries as well. But of course, that brings with it the challenges. You know, Cicely Sanders always said, palliative care is low tech and high touch. And the more you bring in technology, the higher the tech becomes and the lower the touch as well. And if we're looking at the use of technology, the whole bioethical side of it actually hasn't kept up with the developments in technology. So I think there's no simple answer to that. I think there is an increase in the use of technology, but I think we, from a palliative care point of view, have to look at how it impacts what we see as our principles of providing palliative care. But I do think integration, education, advocacy, of course, the use of technology, and I think the outside palliative care community being willing to participate in the telemedicine aspect, the education of the community, as has been seen done so effectively in Uganda and in the Rohingya camps in Bangladesh as well. So we have models that we can actually build on if we really feel seriously about this, and I think it can be done. But it's bringing in all those different elements. And as I say, looking at the bioethics of it as well as we move forward.
Thank you very much, Joan. It's very important that we don't miss out those populations. And just to crown it all, I want to ask Christian, we've talked about essential medicines, we've talked about essential technologies, we've talked about systems, we've talked about innovations, we've talked about technologies. All these need resources. And as palliative care providers, we don't hold the resources. The people who hold the passes for us to achieve these things are the politicians. Christian, how should we engage the politicians to achieve this, to ensure that we have better access to medicines, we have better access to technologies, we have systems working?
Thank you, Manuel, and thank you for this question. I think one of the best strategies is advocacy. And also we need to learn politician language. You know, sometimes we are technicians, we are physicians, we are working with the patient, but sometimes we don't know how to translate patient language to politician language. Because if you come to the politician and say, oh, we need palliative care, we need morphine, we need to be part of the essential medicine, this is really difficult for them to understand, even if it's part of the priorities, to say, how can I engage? How much can I engage for? How much can I put? How much can I invest in palliative care? So I think one of, this is my opinion and my experience is, so we need to learn also which the language can use. And I like one of the quote in the Bible say you can't speak Romance with a Greek language. So you need to learn Roman language. So you need to learn Roman language to speak to Romans. So in that context, politicians need to know what is the impact of doing this action to the population. What is the direct and indirect impact to the patient? What the direct and indirect costs? What will be the benefit for the country? What will be the image for palliative care for the country? How policy will change that? So if we can be able to respond, then they will be able to take actions. But bringing advocacy with a technical language, it's kind of difficult. And sometimes we are conflicting with them because they say, oh, this group of people, physicians, they think they are the demigod and they need everything, to be put on the table. And sometimes they don't understand that we have so many priorities. We have transport, education, and defense. And so we need also to understand what is the language and learn from us. And it will be a great strategy and a great step on my sense. Thank you.
Thank you very much, Christian, for that, on giving us the tips on how to achieve what we want to achieve by engaging the men and women who hold the path. I want to go back to each one of the presenters to give us, instead of, because I don't have any questions in the chat, but I thought that each one of us has one last bit they feel should be used to fit in the puzzle. And so I'll go back to each one of us to make a single recommendation before we go into the next session. So I'll go back to Anna. Anna, what is your last parting shot?
Okay, thank you, Emmanuel. Actually, I wanted to zero in on the technologies in terms of radiotherapy machines because I'm a radiotherapist myself. I mean, there is actually, you can work with UN bodies like International Atomic Energy Agencies in terms of negotiating for equipment in the country, and also even the countries that have got equipment, sometimes the machines are not working, and you actually negotiate for service contracts and also maybe plans for getting new machines. And on the ground, the way the gradation is given can be such that is altered fractionations where the patients get short courses, and this leaves room for other patients to receive their radiotherapy. So the way we do it and also how we can make sure that we've got equipment will make it possible for patients to access radiotherapy.
Thank you very much, Anna. Miriam, do you want to build on what Anna has said?
Yes, I think my take home would be around a critical role of collaboration. I think the days where we sort of operated in silos, whether it's as a single unit, whether it's as a country, I think there's definitely strength in numbers. And so if we're able to expand our advocacy efforts to regional contexts, if we're able to even really build towards, regional centers that can provide some of these for our patients, even as we try to build our in-country, looking at whether we can have production hubs that are able to support a region, I think is really the way to go. And I think just, the whole concept of collaborating, even from the grassroots level at the advocacy, I think lends itself to actually pushing the needle much further on the continent. Thanks.
Thank you very much, Miriam, for that. Zippy.
I think the Miriam and Anna have said quite a lot of things. I want to be a bit controversial and just say that I think one of the things that we need to remember is that also the role of the patients in all of these things. And I'm saying this because our National Cancer Control Program, the head of the NCCP, I was interviewing her for something else, Dr. Nyangasi, and she told me they procured a lot of colostomy bags and then they were not able to use them because they bought the wrong colostomy bags. They did not involve the patients in asking which colostomy bags do you want, which are the ones that fit well and don't leak. So again, the role of patients is very important. The other thing I was going to say that sometimes when we, I've seen this and I've experienced it, and it's really sad that the patients who are palliative care patients towards maybe incurable, stage 3 and above, or dying or whatever, sometimes radiotherapy is tested on them. A new machine is being calibrated, give it to the palliative care patients. This machine is not the best machine, send the palliative care patients there. And I think this is not right. This is not right. So we need to also to ensure that whatever we are giving to our patients as palliative care patients, whether it's chemotherapy, radiotherapy, it's of the best quality. Even if it's not going to cure the patient, it's going to increase survival and mitigate the pain and suffering, all the symptoms and the rest. So again, I think the focus should be on what is the best thing for our patients to make them have a good quality of life, whatever we do.
Thank you very much, Zippy. Theonest, what is your parting shot?
My parting shot is saying, I want to second on advocacy that Chrissy has evoked, is that if we want to talk to decision makers, we need to use two things, fact and figures, meaning it's better than we speak Roman to Roman people. However, we have to tell them what is there in terms of data. That's I want to emphasize on research. We are still poor in research, and that's what most of the time politicians don't understand us, because we don't show them the impact and how big the problem is, and they can't trust us sometimes. Thank you.
Thank you very much. And Hategekimana, are you still there? Have we lost him?
Yeah, I think we lost him. Yeah.
Okay, let's go to Joan. Joan, your parting shot.
I think it has to be about the children, Emmanuel.
Okay.
Is that, and the human rights aspect of this is that we need to remember that children's rights are absolute rights. They're not progressive rights. And if we are not providing the essential medications, the technology that help us to do that, is that we are actually allowing these children to suffer. And I think there needs to be a much stronger voice in advocacy for the right of every child to receive palliative care, to receive the medicines in pediatric formulations, and to have people trained in providing palliative care and pain management to children. And that includes neonates as well. And I think that is just never forget the children, and let's work harder for them.
Thank you very much, John. Christian, do you want to say something?
Yeah, I think, as you said, it's we need also to emphasize what the comment from Miriam. We need a South-South collaboration and the best practice. There are so many things have been done in Uganda, some things have been done in Kenya, in South Africa, in some part of the Western African part. So if we can creating a very strong partnership and network between on our best practice, I think that will be one of the best way to improve at least because there are something have been done in Kenya, could be learned in Rwanda, could be learned in Uganda, and South Africa, and also Zimbabwe. I think this best practice partnership could be one of the best steps on integrated palliative care. Thank you.
Thank you very much, everybody. I can actually mention the words integration, advocacy, innovation, telemedicine, collaboration, technologies, and all these have come up as we talked about essential medicines and technologies in palliative care. The patient voice, I know we are going to discuss that in the next session, but Zippy brought it out so nicely for us to understand the role of patients in this, and also acting with caution and having patient safety in our minds. So the task is huge for us. As Theoneste said, we need to go to politicians with the figures. And at times we are so busy delivering the service that we forget about engaging the powers that be. And as Christian said, we are the technicians, but they have the money. And so we have to keep one eye on the ball and another eye on the guys who have the money. So thank you very much, ladies and gentlemen, for sharing with us in this session. And I would like to thank my co-host, Christian, and all of you, especially those who were able to generously stand in for those who were not able to attend. Thank you very much. Let me now hand over to Christian to take us through the next session, which will be focusing on acting on patient voices in palliative care, children, adults, and the elderly, as mentioned in that part. Christian, over to you.
Thank you, Emmanuel. Thank you for the great moderation, and thank you for the panelists. So we are still continuing with some of our panelists, with the Theoneste Maniragaba, which is the clinical oncologist at the Rwanda Cancer Center. Of course, we have Joa Maston, who is I call you the mother of pediatrics palliative care in Africa. So allow me to use that nickname. And Anna Nyakabau, which is radio oncologist from Zimbabwe. And also, of course, the rest of the panelists. As I said, we still sending our positive vibes and prayers to our colleague from Ethiopia and Sudan and other parts in African countries, which is they couldn't attend, this meeting, important meeting due to political issues. So we are going to discuss about capturing and acting on patients' voice. And one of the question, how do you capture patients' voice? And my first question is to Emmanuel, why we don't have patients here to talk by themselves among the panelists?
Thank you very much, Christian. We're actually supposed to have a patient, but I think the challenge we had is that we are not paying the registration fee for the patient. And I think that has been a major challenge for them to join. But I know we invited at least a patient to be on this panel. But I realize with hindsight that we should have gone all the way and paid the registration fee and then have the patient, excuse me, on the panel. So Christian, that's a very important observation you've made.
Yeah, so on behalf of Emmanuel and I, we apologize to not have a patient here. So we are not even sure that the patient voice will be well heard, but let's trust from our experiences and working with the patient, we'll be able at least to raise their voice. So Joa, I'm always curious, pediatric is not my field, even if I have some experiences, but how do you, from your experiences, how can you say that the children's voice is well heard as they have their own way to speak and their way to express their suffering? Thank you.
Thank you, Christian. Yes, I think as you've said, that the children's voice is often not heard, sometimes for cultural reasons. But I think we have to see ourselves, we're the story keepers for these children. And when the child can speak, they are the most effective speakers. Some years ago, and Emmanuel will remember, we did a project in Malawi expanding children's palliative care. And one of the most effective experiences we had is when we got children with life-limiting and life-threatening conditions to speak to the Ministry of Health. And that actually led to children's palliative care being included in policy. So I think sometimes we try and protect the children when actually they want to speak for themselves. I think we need to remember that as the story keepers for these children, and especially for those whose lives are very short, that we need to record those stories. And I think we need to listen to the voice of the children. When we started the International Children's Palliative Care Network, our very first declaration of the ICPCN included that we would listen and respect the voice of the child. And maybe we just haven't been doing that enough. So I think it's to encourage people to write down when that child can't talk, we can still tell their story, we can still be their voice. When they can talk, is to allow them to be part of our advocacy with all the relevant protections and permissions. And of course, to remember there are many older children and young people who fall under children's palliative care. And they speak through their own words, but we're using more and more, we're using poetry to allow them to express how they are feeling, what they are going through. And I think that medium can be really, really powerful. And certainly our poetry group is using that. So yes, it's up to us. It's not up to the children, it's up to us to allow them to bring their voice forward and to have them listened to.
Thank you, Joanne. And thanks for this. 10 years ago, when I was starting doing palliative care, one of my mentors told me that you need to treat child and parent as one person. What do you think about it?
In some ways, I think you have to have them working together, but you do have situations where the child's needs and what the child wants is different to the parents. And of course, very often we let the parents speak for the child when in fact the child is able to speak for themselves. So while they are a unit, we talk about the child and the family as the unit of care, I wouldn't say they're one person. They're two very distinct individuals with their own way of expressing things, with their own way of experiencing, with their own emotional and spiritual expression as well, which can be very different. And we've often had cases where the parent has said one thing, and when we've taken the child on their own, the child has said something very different. So even when it comes to evaluating pain and symptoms, where the parent says, no, that child has got, sort of a 3 on the pain scale, and the child, when you talk to them, says, well, actually it's a 6, but I know it upsets mommy when I show that I've got a lot of pain. So no, I don't, as a unit, but not as one person.
Thank you, Joanna. So my second question will go to, we are lucky to have an oncologist here, Theonest, Miriam, and Anna. I know that tumor board is really important to discuss about the diagnosis, even the management of patients, the disease. So how do you bring patient in the discussion? Do you often invite the patient to the tumor board? Do you invite patient to be part of day management, or do you decide on behalf of the patient? So can you just in a few words describing your experiences, how do you involve patient in your daily practice? Starting by Theonest.
Thank you, Dr. Christian, and thank you for this very good question that brings my emotions about how we involve our patients. To be honest with you, we don't do as to expected. Why? Taking the example of Rwanda Military Hospital at our Rwanda Cancer Center tumor board, we weekly hold tumor boards whereby we bring difficult cases that we think that by a multidisciplinary team, we can do more. However, most of the time, we come together as clinicians, say surgeons, radiation oncologists, medical oncologists, and other departments to discuss with the theory. However, the patient, most of the time, they are away. We bring some cases which we think that by observation people can give their insight. However, it is not that common. What I can bring maybe as a good insight to how we involve the patients, that when, for example, the tumor board decides, sometimes we recommend to the treating doctor that before he or she implement the decision that has been taken by tumor board, they bring the patient, they discuss, especially for those who can contribute, who are still aware, the plan of management, they give pros and cons, and then the patient can accept or not. However, according to what I have seen, most of the time, what you have decided in tumor board is like the one which will be observed by the patient. So we really need to improve on our behalf so that patient be part or really part of our management. Thank you.
Thank you, Ernest. Miriam.
Thanks, Christian. And you've raised a very critical point around how to get the patient's voice always at the center of care. And I think it really comes down to shared decision making. And part of our experience has been, again, as Theonas was saying, the tumor board is very technical. You're probably discussing the nuances of care and which therapeutic agent, which technology to employ, sort of from the 30,000 feet view. And so what we decided to do as an institution was take it a notch higher and set up a multidisciplinary breast clinic, which is actually one of the abstracts that we're presenting at this AOTIC, which I'd encourage us all to sort of have a look at. And we're looking at our initial experiences. And what we found was very telling, because we had this concept in our mind about what the treatment plan should be, but then we found that at least 40 to 50% of the time, that treatment plan changed based on the patient's preferences, based on maybe their circumstances. And so it's more, I think, one of those, and we sort of looked at the initial satisfaction. Patients felt that they had more agency in terms of control. And it was also very critical that we did this at the start of their treatment. So they sort of have the 30,000 feet view, because what used to happen is you kind of got the treatment based on whoever saw you first. So if you saw the surgeon, you would blink and you'd be in surgery, or you saw the medical oncologist and you'd be having chemotherapy. And so it was very important for them to sort of get that overall broad view of this is what we intend to do, and then sort of sit down and say, well, this is what we think, but what do you actually want? And sometimes patients would say, you know what, and we've had older ladies, for instance, would say, I don't want to have chemotherapy. And I've had, really bad experiences about it. And you would say maybe try and demystify, get them to talk to other peers, and they would still say, you know what, I don't want to have this. And we would say, okay, it doesn't mean that you're not going to get your care, because it's important to realize it's all about giving you the tools to make an informed decision. So you'd maybe put her on hormonal therapies after maybe her primary therapies and stuff. And so it's always about restoring agency and then autonomy, because at the end of the day, as healthcare providers, we are basically partners in the care, but it's a patient who's in the trenches and walking the journey. And it's really giving them the tools to know how can they make a best informed decision and how can we help support them. And so part of the multidisciplinary breast clinic was basically having you talk to the surgeon, you talk to the medical oncologist, you talk to the radiation oncologist. But a critical component of the what we felt was a missing piece as well was basically the supportive component. And so we've had to incorporate, because the questions we would usually get were actually not necessarily about the chemicals or the treatments. It was more about nutrition. It was more about their wellness. So we've had to incorporate our palliative care team, our nutritionist, our psychologist, all really as part of the clinic to actually ensure that we're managing our patients holistically. And so the idea is this is not necessarily unique to our institution. Sometimes we say we don't necessarily have the workforce, but as Joan was mentioning, with telemedicine and telehealth, these are things that are actually practical for our patients. And we may not necessarily have all the specialists in a single center, but it's definitely something that we could employ, not just for breast cancer, but for all other cancers, and look at some of these technologies to help support these. Thank you.
Thank you, Miriam, for the great insight about how to bring the patient. Anna, just in brief, from your experiences.
No, thank you very much. A lot has been said already. Perhaps what I can add is the fact that, for the patients to make informed decisions, they need to have been educated about their problem. So there is need for patient information such that someone would have sat down with the patient to explain, and if necessary, to give them material to read and link where they can go and read about the illness and also the treatments and their complications. And then finally, when the multidisciplinary team has met, they can even be given an opportunity to come and speak to the various members of the multidisciplinary team so that they can ask questions that are specific to the various members and they are explained directly to them, because sometimes it helps them when they hear it from the voice of whoever the professional is, than something that is passed on to them through somebody else. Thank you very much.
Yeah, thank you. Vedast, from your experience in treating the pain, I know physical pain is one of the most expression by patients. Do you think, from your experiences, that the patient voice is well heard during part of your project?
Thank you, Doctor. So I do think it is not well now. It is not well at level which is really effective, as I can say, because pain was something which was not a priority. Let me say in this country, but not only this country, but even other countries. So if we are still struggling with making this pain as a priority, it means that we need also to work on the increase the awareness about patient. So the patient, even those patient knows about that pain. So if the patient knows that they have the right to be treated from pain, so that's where now they can raise their voice and say that we need pain medicine. We need to be cared for pain management. So now we still need to increase that awareness about pain. So we need to educate patients that they need to report their pain, because still it is something which we need to work on. So among healthcare providers, they need to consider pain as something which is also important. So we are struggling with making it as a vital sign. So it is recommended by WHO, but of course, you will find that some nurses and doctors, they will consider only other vital sign and not consider pain as a vital sign. So we need now to work on it and then bring this pain into other vital sign and then educate. So in patient voice, we need also to educate patient so that they can know how to even to ask help. So someone will not ask if he doesn't know what to ask. So we need to empower our patient with knowledge about some cancers, some information about cancer. So we need to increase the awareness about some cancers. So through like support group, I've been reading some support group where some patient can ask a question about any disease. Let me say like breast cancer. They need to know about some breast cancer, like sign and symptoms, but also know the side effects from chemotherapy. So if they know the side effects from chemotherapy, let me say, use this example, they can even know what they are expecting after they get this chemotherapy side effect. And then they can decide to go with chemotherapy or even not, because we need to involve patient in decision making. So we are still, my point is to tackle on increasing the awareness about this disease, about cancer, about palliative care services. Let me say services, because sometimes patient can even die in pain because he doesn't know where to seek medication, because he doesn't know that there is pain medicine which is available. So we need also to increase the awareness among our patients so that we can also include them in decision making. So not only patient, but also healthcare providers, they need to know that they will not go and take decision without involving our patient. So we need both healthcare providers and the patient to be educated on how important it is to involve our patient into decision making. Thank you.
Thank you, Vedas. And one of the discussion and during the experiences we had here in Rwanda, and part of the discussion I had with the patient is most of patient told me that the challenge they have is physician or mostly healthcare providers are living on the pedestal and patients are on the bottom on the relationship. So, Emmanuel, how do you think about it?
Kristen, can you ask that question again?
So one of the challenge is communication between physician and the patient, because one of my patient used to tell me that physician are on the pedestal and the patient are on the bottom. It's why their voice are not heard enough. Do you, from your experience, I think is the same? Because it seems like physician or healthcare providers consider themselves as the demigod and the patients are just the receiver.
That's a very important question, Christian. You know, my background is in family medicine first. And in family medicine, one of the things they taught us when I was studying, when doing my postgraduate in South Africa, was that even the way you arrange the sitting arrangement in the consultation room is important. If you bring a throne for the doctor, and then you bring a ramshackle chair for the patient, the communication is already made. And so you are telling this person to ask that demigod what the problem is. The communication is already distorted. And so that is very important. So it starts not only with the way we position ourselves, but also the way we communicate to the patient, the way we, the attitude we throw to the patient. That is very important. And that's the basic. And then comes to the point of creating room for the patient to ask questions, for the patient to feel comfortable to ask you the questions and to know that their questions and their comments are very important. Now, that is not only for palliative care providers, it's for all health workers. And at times, the people, you will be shocked by the people who teach us that approach. One time I attended the HPCA conference in Cape Town, and there was this professor who is, I think, teaches something to do with traditional African healing or something like that. And he said that's where the traditional healers beat us, because they talk with their patients somehow about the same things that they understand. And I think it also comes to the issue of packaging the information we give to patients. So the way we position ourselves, the way we create the environment in which we interact with them, the language we use, the attitude we have, the packaging of our information. And I think that's a major issue. It has also been demonstrated by COVID-19 that we often think that communication has happened when it has not happened. And people are taking other people seriously and not us. And they are listening to other people and they're not listening to us. So I think communication is a major issue, as you've stated it. And we need to calm down our high horses so that we can hear both literally and otherwise what the patients are saying, and them to hear what we are saying. And then we get the best outcome out of the interaction we've had. Thank you very much.
Thank you, Manuel, for the great answer. So, Miriam, just a few seconds before to move to our last question.
Sure. And I think I was just to echo Emmanuel's comments about we're moving away from the paternalistic approach to medicine, where we come down from the mountain with the 2 tablets and tell you to take them, and more to encouraging patients. But for me, it was just to talk about vulnerable populations, because what I find is sometimes we believe we've communicated, but there's frequently a lack of understanding. So patients listen to you talking, and then they go and ask the nurse, what did we say? What did the doctor say? And so it might be important to ensure that, again, strengthening the team, having the nurses or other healthcare allied workers who are able to actually discuss, and especially for vulnerable populations where people like my mom, for instance, will never talk back to the doctor. She says, Dr. Mesema, the doctor has spoken. And so just encouraging that environment. So they get a little shocked when you ask them any questions and they're like, no, you know. But I think it's the onus is on us to be really, really careful about these vulnerable populations and ensure that despite them not necessarily having the voice, we still are able to make sure that their voice is featured. Thanks.
Thank you, Miriam. So before to give the mic to Anna to wrap up about all those two sessions, I have a very pragmatic question to you, starting by you, Miriam, because you are the last who have the mic. So if you are nominated as the Minister of Health in Kenya, what will be the first action to make sure the patient voice will be heard? One action.
One action. Okay. I think the one action would be pretty much just setting up collaborative units where we're actually able to bring in and engage the patient, like expand the forums for them to, one, have access to information in the language that they understand, because that's the other thing. You have information, but it's in English, nobody understands it. So making sure on a grassroots level that this information is provided in a language that the patient understands, and having those forums where they're able to regularly engage with the health system and actually interrogate this information and have discussions.
Thank you, Miriam, but I don't understand your language because I'm your patient now. What's your first action, Honorable Minister, concretely?
My first action is to ensure that health workers understand the importance of bringing in the patient voice, because if they don't understand it, then we can talk until the cows come home, but until we educate the health workers to incorporate patient voice in their regular and shared decision-making into their processes, then it will never percolate down. So that would be my first port of call, addressing the healthcare workers and improving their education first.
Thank you, Honorable Minister. Honorable Joa. Joa?
What would be my first action?
Yes.
I would set out a survey of patients to find out what their needs are, and that would have to include children and children who can speak as well. Have a national survey of patients' needs and patients' feelings about the health system.
Thank you, Honorable Joya. Vedast, you are now the Minister of Health in Rwanda. First action you can do for patients' voice to be well heard. Vedast, are you there? No, I think we lost him. Emmanuel, you are appointed at the African Union, as always as yesterday.
Well, my action will not be very different from Miriam's, but would be really to ensure that at every level of the health system, there is a patient health work interaction system, a fair patient health work interaction system. In the old system where I worked, we used to have patient surveys, patient satisfaction surveys, but those, again, were more of us designing what we want to get out of the patient. But I would go for making sure that at each level of the health unit, you have a patient health work interaction point where patients are able to air out what they want to see happen in the health system. Thank you.
Thank you, Emmanuel. As Vedas is not yet connected, ZP, would you mind respond? I know, okay, Vedas, you are there, thank you. Vedas, can you hear us?
Yes, doctor.
Yeah, I was saying.
Yes, I hear you.
Okay, I'm saying if now you are nominated as the Minister of Health in Rwanda, what will be your first action to make sure that the patient voice will be well heard?
So yes, what I can do, it's like in a few words, it's building the relationship so between patient and healthcare providers. So because through this relationship, that's where now we need to collaborate and based on evidence. So we need to involve something like, so if we want to improve, where do we want, where are we coming from and where do we need to be? So are we try to improve like the evidence-based in palliative care, of course, focusing on patient voice, because I need to see if what I'm doing is really what is needed by patient and family. So I need to bring both family, patient, and healthcare providers together through this building relationship. And then I'll be sure that whatever I do, it's regarding to the need of patient. Thank you.
Thank you, Vedast. Zippy, as I know, we can have a 2 Minister of Health in Kenya, so you'll be the Vice President of the country.
I will support my Minister of Health, who is Miriam, in what she has said, and support all these other advocates, what they have said. But I think I'll take an example of what's happening in Kenya. The NCD interagency, sorry, my video is off. The NCD interagency committee in Kenya has got several technical working groups on diabetes, hypertension, and stroke, on cancer, on chronic lung diseases, and we are forming others as well on hemophilia and blood diseases and the rest, and rare diseases. I would ensure that this type of work or technical working groups have a patient or 2 or 3, the presence of patients in them, whether they're children or adults, they have to be there. And I would avoid tokenism, so that they're not sitting there so that we can say we have patients in our technical working group, but we listen to what they're saying, we put it down, we plan with them, and we implement. So they're part of the process from A to Z. It's about them, and nothing about me without me. So I would really focus on nothing about me without me. No tokenism, but real involvement and listening to them, and working with the civil society, because civil society is the voice of the people. Patient-led organization is the voice of the people. Yeah. Thank you.
Thank you.
But I'll support
Zippy.
Miriam. She's my minister. I'll support Miriam.
Thank you, Zippy. This is a let's say, conclusion. I would like just to give Anna, can you just wrap up in a couple of minutes? Then we'll be able to close our session for this evening. Thank you.
Oh, thank you very much. This has been a very exciting, informative session. When it comes to access to medicines and technology, we're talking about policy in terms of essential medicine list, and then also guidelines on morphine prescription, and then also policy on prescription or nurse prescription, which is something that is new in terms of the fact that nurses are all over the country, such that access is increased. Advocacy to the politicians, we must know how to communicate with the politicians. Training and education for the healthcare workers, and also even the pharmacists who are supposed to be ordering the medications so that they are always available, and the patients themselves and all the other stakeholders. Collaboration, patient voices, north to south. I mean, we should be able to collaborate with the patients so that they can make the choices. And then we mustn't forget the children, because they are very important. So technologies and access to radiotherapy, we must make sure that radiotherapy is available, because most cancer patients need radiotherapy at some stage during their treatments, almost about 50%. And we must leverage on telehealth, especially during these days of COVID-19 pandemic, where the touch is going to be compromised because we're not always going to be available. So the buzzwords include integration, advocacy, telemedicine, innovation, and then operational research, and communication, and collaboration. When it comes to patient voices, ZP talked about nothing about me without me. It really summarizes it all. We need to be able to do engagement with the patient and communication and record their voices. We have shared decision making and also increase awareness of disease and symptoms so that we empower the patients so that they can know what to ask. And when it comes to children's voices, also, we need to be able to actually listen to them. And, we must be aware that children may not always communicate verbally. They can communicate through play, through music, through art, even adults themselves. So we must not only pay attention to the verbal communication, we should pay attention to the other kinds of communications. And I think it is possible for there to be access to medicines. It is possible to engage patients in the African context, and the future is bright. Thank you very much.
Thank you, Anna. So we have 30 seconds. I'm going to take 15 seconds, and then Emmanuel will be concluding. So just on behalf of our committee, Emmanuel, my partner, Emmanuel and I, we are very happy, and we thank all the panelists since yesterday. It has been 2 days, a tremendous day of discussion. And I would like also to thank AORTIC for always putting palliative care among the priority, which is such an encouragement for all palliative care workers. I thank also all the panelists and all the scientific committee from AORTIC. Thank you so much. And Emmanuel.
Well, great. That was truly a wonderful session, I must add. And Christian was asking all the panel members all these questions, and we were feeling a bit left out here, Christian. So what I did was I was asking Zainab what she would do if she was the Minister of Health of South Africa. So Zainab, what would you do for palliative care in South Africa?
Well, I think the first thing would be to direct more funds, more money to palliative care. I mean, I think that's where the buck stops there. There's just not enough money in palliative care. So I think I would legislate that palliative care training becomes compulsory for all healthcare providers, nurses, doctors, all healthcare providers in various forms should be trained to be able to provide palliative care. And of course, the essential part of palliative care training is communication. And that's where being able to listen to the voice, to hear the voices, to give the patient their voice, the opportunity to speak. So yeah, I think it's all about the bucks, really. It's all about the money, because that's the problem we have. We don't have enough palliative care nurses here, and yet we probably have more resources than some other countries in Africa. So we don't have enough palliative care nurses here. We don't have enough advocacy, especially when it comes to drug availability. And we really don't concentrate at all on educating our patients. So yeah, as a Minister of Health, maybe there should be a department to see to this. I don't know. If I have all the money in the world, maybe I'll do that. And maybe I'll get Joan to assist with setting this up. I don't know.
Well, great.
Yeah.
Well, certainly I think the dialogue leaves much food for thought, given the experiences that we've heard in this particular session. But I think what comes through clearly is that there's a dire need for stepping up palliative care and responding appropriately and timelessly to the needs of the patient. And I was thinking in oncology, we continuously use the term multidisciplinary teams, and certainly in palliation, the clinician, the role of the palliative care nurse, the social worker, the family members, as well as the community, are so important to form part of that care pipeline for the patients. I mean, in South Africa, we use the term Ubuntu, I am because you are, and certainly bringing out the humanity as a collective to care for the patient. Certainly much food for thought as we move forward. So thank you very much for this particular session. Delegates, as we conclude this particular session, I want to please draw your attention to ask you to please join us for the plenary on stream 1. which will start in a few minutes. And after the plenary, I want to please ask you to come back and join us once again on stream 2 for 2 sessions that we had to postpone earlier on in the day due to the technical difficulties, and that would be the session on best of the best abstracts as well as neuro-oncology, and that would take place immediately after the plenary right here back on stream 2. So we'll see you then. Thank you very much.